Welcome to my first video essay on the heart. So to begin, let's go over the different action potentials between the ventricular and the pacemaker cells here. So in our ventricular or contractile cardiac muscle cells, basically what differs from a skeletal muscle or a smooth muscle is that we have this plateau here. So let me go over this real quick. So in a ventricular contractile cell action potential, basically you have your RMP stage 4, which is maintained by potassium efflux. And then once you get a depolarization from the AV node, what's going to happen is that we hit threshold and then we have an influx of sodium into the cell, and that's stage 0. And then we get up to I transient open 1 and 2, and those are potassium and then chloride efflux channels that are going to get us over this little hump here. And then once we get over that hump, we have our plateau phase where we have an influx of calcium. We have a voltage gated calcium channel, and then we have an ultra rapid, rapid, and slow potassium channel there. So what's going to happen is that these ions are struggling to influence the RMP or the membrane potential, and so you get this plateau here. So you have the influx of calcium, and then you have the rapid influx, the ultra rapid influx of potassium to try and bring us back down to RMP, but that doesn't work against calcium, so then you need the rapid channel, and then you need the slow channel, which is finally going to get us over that hump, and we're going to return to just a normal potassium current. So these are voltage gated, and then we have our normal potassium current that's going to bring us back down below threshold to our RMP there. So here, potassium channels are open. Then for a short second, we have sodium channels that open up that are going to depolarize us. And then we have chloride and calcium channels that open. And then we have our series of voltage-gated potassium channels. And then we have our, probably, I would say, potassium leak channel that's going to drop us down below back to RMP there. And then in our pacemaker autorhythmic cells, it's a little bit different. We don't have an RMP here, and these are the action potentials that are generated by the SA node here. So, or this is how they're generated, I guess. But what happens is we have a slightly more positive. So in the contractile cells, our RMP is like -90. We don't really have an RMP, but we're starting at about -50. We're starting a little more positive here. And we have only 3 phases. We have phase 4, 0, and then 3. And phase 4 is dictated by what is called a hyperpolarized cyclic nucleotide gated channel. So what's going to happen is this is going to slowly allow Na plus or sodium to enter into the cell. So we have this constant creeping upwards depolarization. We have these like tiny little pacemaker potentials is what they're called. We have these pacemaker potentials that slowly get us to threshold. And then once we get up to threshold, then voltage gated calcium channels open. And that's what causes our major depolarization. So Na gets us to threshold via the HCN or funny channels. And then that opens up V-gated calcium channels, which are going to depolarize us. And the reason that you see these kind of wider tips of the action potential is because these voltage-gated calcium channels take longer to close than, say, a voltage-gated Na channel. And then our potassium channels are going to repolarize us and get us down back below threshold. And then those funny channels are voltage gated, right? So once we dip down below threshold, those funny channels, the HCN channels, are going to open back up, and we're going to have our slow increase of Na into the cell, which is then going to cause our depolarization again with the calcium channel, and so on. So that's how that pacemaker channel is going to work there. So then we have the electrocardiogram. So I have the different waves here. We have P, Q, R, S, and T waves of the electrocardiogram. So what's causing our P wave is going to be the depolarization of the atria. That's our contraction of the atria right there. And then our QRS complex is known as our contraction of the ventricles. And then our T wave is the repolarization of the ventricles. The repolarization of the atria kind of gets lost within the QRS complex. Yeah, and the reason that you have these different inflections here, so staying steady here is our isoelectric point. And then whenever you have a negative, so if we look at our heart here, we have a 2 lead, we got the negative and the positive leads. So anytime that you have a negative depolarization force vector that's moving towards a positive lead, that's going to give us an upward inflection. And then if you have a negative towards a negative, that's going to give us a downward deflection. So our P wave is negative to negative, or negative to positive, and it's up because our atria are contracting and that force vector is pointing towards the positive. But then our Q wave, let me grab my notes real quick. I should have this. Let's see. Yeah, so that P wave there is our depolarization of the atria. The Q wave is a downward deflection and then return to isoelectric, which I believe would be caused by some sort of contraction or some sort of depolarization in the ventricle wall that is causing our force vector to go up towards this negative here. So what happens is in the AV node delays the signal from the SA node. It sends it down to the bundle of His, which then splits off into bundle branches down the septum. And then those bundle branches are going to innervate the Purkinje fibers, which are going to send those depolarizations to the ventricular walls. And so the left ventricular wall takes longer to depolarize than the right side because there's more cells, there's more muscle. And so temporarily you're going to have, when that spot depolarizes, you're going to have a negative electrical force vector that's traveling towards our negative lead. And so that's where you get your S wave going down like that. The S wave is the second downward deflection and back to isoelectric caused by the depolarization of the superior left lateral ventricular wall. And the Q wave is another one of those depolarizations here in the heart ventricle that's going to cause an electrical force vector to go up towards our negative lead. And then, of course, our R wave is our large upward deflection because we're sending a big, huge negative force vector down to our positive lead there because that whole ventricular wall is contracting. And then our T wave is going to be our repolarization of the ventricles. So we have let's see, so that's going up. So we have a repolarization. And when we're repolarizing, we know that the cell membrane is negative on the inside and positive on the outside. So if we're depolarizing, or if we're repolarizing this way, the outside of our cell membranes are turning positive, and that's creating a force vector that travels this way. So you have an opposite charge force vector going to our negative lead, which causes an upward reflection. And then what's going to happen is, let's see. So that's our repolarization of the ventricles there. All right, so now let's move into our hypoxia here. So if we have something called an N-STEMI, a not ST elevated myocardial infarction. This is caused by kind of moderate hypoxia here. So if we have our heart, I've drawn an area of the wall of the ventricle that is not receiving oxygen. So what happens is when oxygen is not getting to those cells, and the endocardium most often cannot get as much oxygen as the epicardium because it's not as close to the coronary artery, which is the heart artery that supplies blood to the heart. So what happens is if we're not getting blood there because of an occlusion to that artery, then we're not getting oxygen anymore. And if we're not getting oxygen anymore, then we're not producing ATP. And the heart has kind of its own little internal defense against some mild hypoxia, where it has these channels, these potassium channels, that are inhibited by ATP, or they're activated by ADP. So when we have large levels of ADP and low levels of ATP, because we don't have any oxygen, then those channels are going to open up. And then we're going to start an efflux of potassium, which is going to make our resting membrane potential more negative and protect against these ectopic depolarizations. But it doesn't work very well for very long. It's just kind of a temporary defense we can have. But what happens here is when we have this, so an N-STEMI is usually caused by we have these dying cells here, but it's not transmural. It's not through the entire wall. And so what happens is those cells die and they basically are constantly depolarizing. And so you have a negative outside of the cell. And that's going to create a force vector. Since it's not a very big area, we're going to send an electrical force vector down towards our positive lead, which is going to set our baseline isoelectric point on our ECG to above normal because of that current of injury. We call this a current of injury, a new baseline here. So most of our waves are going to be normal. We're going to have a normal P wave, and a Q wave, R wave. But then what happens is our S wave is going to dip down to where it normally should be. Now, why does this happen? Well, let me think about this. So what happens is when the R wave happens, the whole ventricle is contracting, right? And so the entire, all the cells in the ventricle have a negative outside. And so that's giving us our normal R wave. But then when we repolarize, that's when we get this force vector. Oh, wait. So we get this S here because the EKG thinks that this S wave is normal. It doesn't detect the current of injury because all of the cells are depolarized. So that S wave is going to be back down to normal. Whereas the current is normally elevated because we've got this current of injury. We got this extra force vector that is playing into the heart's conduction. And so we call this an N-STEMI ST depression. Your current of injury has caused your ECG tracing to be above normal. And so then when the heart depolarizes and repolarizes, the S wave is going to go down to normal since our new baseline current is above normal. And then with a STEMI, now this is considered severe hypoxia, severe heart attack. We need to go to an operating room now and clear this occlusion. So what happens here is you have a transmural infarction here. You've got a whole thickness of the wall, endocardium and epicardium, that is going to be dying. And so that's going to create a big old electrical current that is going to travel towards our negative lead. And what this means is that our current of injury is going to cause our ECG to be below normal. And then this is called ST elevated because our current of injury has caused us to be below normal, but after the depolarization, repolarization of the ventricles, our S wave is going to try and go up to normal. And then it comes back down to its hypoxic baseline. So that's our ST elevated myocardial infarction. Alrighty, so now let's go over inotropy, lusitropy, chronotropy, and how the sympathetic and parasympathetic nervous systems affect the different contractile and autorhythmic cells. So in our contractile cells, the sympathetic nervous system is going to increase inotropy, which is the force of contraction of the heart, and we're also going to increase the heart rate. And our sympathetic nervous system is going to increase lusitropy, which is the speed of relaxation. So we have a beta 1 receptor here, which has an affinity for norepinephrine, which is our ligand. That's going to bind to a G protein coupled receptor. We're going to send the alpha subunit to adenylyl cyclase, which is going to increase the levels of cyclic AMP, which is going to activate phosphokinase A. Phosphokinase A is going to open up L-type calcium channels. We're going to have an influx in calcium into the cell, which is going to cause depolarizations and increased entropy, increased heart rate there. Phosphokinase A is also going to act on the sarcoplasmic reticulum by inhibiting calstabin and phospholambin. Now, calstabin inhibits RYR, so when we get rid of calstabin, calcium is going to leave the SR and cause depolarizations, which is going to lead to increased heart rate and entropy. We're also going to knock off phospholambin, which is going to prevent calcium from going back into the SR. And then in our autorhythmic cells here, so we did the contractile muscle cells, now we're moving on to the pacemaker cells. We have our muscarinic receptor, remember that's parasympathetic, so acetylcholine is going to be our ligand here. So acetylcholine binds to this. We're going to send off a heterodimer, which is actually the beta and gamma subunits this time. That heterodimer is going to go and activate a GERK or potassium acetylcholine channel. And so what happens here is we're going to increase the amount of potassium that is leaving the cell, which means we're going to hyperpolarize and decrease the heart rate and increase lusitropy. And then that heterodimer can also come over here to adenylyl cyclase, inhibit the production of cyclic AMP, which is going to decrease the slope of phase 0 and the slope of phase 4 there. And then additionally, so we did the parasympathetic effects there. If we do the sympathetic effects, we have our beta 1 receptor, and we're going to have norepinephrine bind to that. It's going to send the alpha subunit to adenylyl cyclase, which is going to activate cyclic AMP, which is going to activate phosphokinase A, which is going to decrease threshold, so it's easier to send off these autorhythmic signals. And then we're going to steepen the slope of phase 0. So if that happens, these pacemaker cells are going to be going crazy. We're going to be having a lot of them, and that's going to increase our chronotropy and our heart rate force of contraction. The chronotropy is the rate of contraction. Cyclic AMP can also act on these funny channels and open some of them up, which is going to steepen the slope of phase 4. So that NA is going to come into the cell faster. We're going to have those depolarizations faster when we open up some more of those HCN channels. All right, moving on to the cardiac cycle, so pressure volume loops. So during the cardiac cycle, we have diastole and then we have systole. Diastole is the relaxation of the ventricles, and systole is the contraction of the ventricles. So at first here, specifically regarding the left atrium, left ventricle, and the aorta, what's going to happen is during diastole, in the first part, we're going to have rapid inflow. So the bicuspid valve is going to be open up, or another name for that would be the mitral valve. It's going to be open because the pressure in the atrium is greater than the pressure in the ventricle. So we're going to have blood that just passively flows into the ventricle. And that's going to fill up about 70 to 80% of the blood in the ventricle. And then we're going to have an atrial contraction, which is going to top off the last 20 or 30% of the ventricle's volume. And so we see this increase in pressure and volume there on this part of the graph. And then what that's going to do, since we're topping off the ventricle, now the ventricle has more pressure in it than the atrium, and so the mitral valve is going to close up, and that's where we get our first heart sound, or lub. And what happens if the mitral valve doesn't close here, when we contract this ventricle, not only are we going to send blood to the rest of the body, systemic circulation, but think about it, the pulmonary vein comes into the left atrium. And if we contract that left ventricle and that valve's not closed and we send blood back up into the atria, we're also going to send it back into the lungs via the pulmonary vein, which is not going to be good for us. We're going to drown in our own fluids. We're going to have pulmonary edema. It's just not going to be good. So what we want to do is close that valve. And so then what happens is we have a period between the aortic semilunar valve opening up, and we have a period where the mitral valve is closed, and this is called an isovolumic contraction right there. And so we have this big increase in pressure, but we have no change in volume whatsoever. And then in systole, finally what happens is finally we have that pressure in the ventricle that becomes greater than the pressure in the atria. So the aortic semilunar valve opens up, and then we're gonna eject blood into the aorta and to the rest of the body. And then throughout that ejection, the pressure slowly fades as we send out all the blood that we can with our stroke volume. And then what's going to happen is once the pressure in the aorta is now higher than the ventricle, we're going to close that semilunar valve. And this is where we get our dub sound. And this also, a little deflection of blood off of the semilunar valve creates this dicrotic notch. Now this dicrotic notch gets smaller with internal bleeding. And it gets larger, I think, with arteriosclerosis or atherosclerosis. I still need to learn which one is which. And then we have this isovolumic relaxation here, where we have no change in volume in the ventricle, but we have a big decrease in pressure back down below the pressure of the atrium. And then the mitral valve opens up again, and the ventricle starts to refill, and we are back in diastole. So now for our pressure volume loop, same kind of thing that I just went over. But we have ventricular filling, going to cause the mitral valve to close, isovolumic contraction, the aortic valve opens, we have ejection, and as we lose pressure, the aortic valve closes, we have our dub, we have isovolumic relaxation down below the atrial pressure, and then we start to fill up that ventricle again. All right, so that's the cardiac cycle. Now let's go over calcium and the heart. So the heart primarily uses extracellular calcium, and we have a mechanism in the heart called calcium-induced calcium release. So what happens is an action potential from the sinoatrial node is going to propagate down this T tubule. It's going to open up L-type voltage-gated calcium channels and allow an influx of calcium from the extracellular fluid into the cytoplasm of the cell. Now this calcium is going to bind to ryanodine receptor channels, which is going to cause calcium to leave the sarcoplasmic reticulum. And then that calcium leaving the sarcoplasmic reticulum is going to bind to troponin, which is going to rip off tropomyosin from filamentous actin. Our myosin head's going to bind there, and we're going to have our contraction of our heart muscle. And then what's going to happen is that calcium is going to get pumped back into the sarcoplasmic reticulum by the circuit pump. And then we also have this sodium-calcium exchange pump, where we're going to pump in 3 NAs and pump out that calcium back into the extracellular fluid. All right, so that's my video essay, whole 26 minutes. It's pretty good. It's some pretty good stuff right there. But alrighty, I appreciate you watching. Have a good night.